Good afternoon. Good afternoon. Thank you. Well, I'm honored to be here, and I'm hoping that you'll bear with me as we walk through both some of the work that's being done and also some of the information that we've gained as we've been doing the work. I am an emergency room physician, and much of my work has come out of that particular practice, but it's informed some of the public health practice that we've engaged in. Just taking a look at this slide, I think the image is illustrative of the state of the art of emergency medicine as it relates to interpersonal violence. Hospitals and emergency departments have become extremely skilled at addressing the corporal consequences of violence, but not the psychological consequences, even though they result from the same event. There exist robust protocols and programs for child abuse, neglect, domestic violence, and sexual assault in hospital settings, but little to nothing for victims of community violence. We encounter patients after they've been violently injured. Some may see this as being too late, but we feel it's critical. It's a critical movement for intervention, or moment for intervention, for violently injured young people. Just with regard to the scope of the problem, I'm going to give you a little bit of history, some of which I'm sure you already know. Violent injury is the #1 cause of death among African Americans between the ages of 15 and 34. It's the second leading cause of death among Hispanics, and it's number 5 in terms of leading causes of death among non-Hispanic whites. Over 150,000 incidents of violence against African American males ages 15 to 34 were treated in hospitals in the year of 2011. That roughly makes about 1 out of every 41 young men in this demographic group. In Philadelphia in 2012, there were 332 homicides. 80% were African American, 88% were male. 23 were juvenile, 7 of those who were under the age of 10. And there were over 1,400 shootings, 95 juveniles, 17 years of age or younger. This graph, I'm going to walk you through this briefly. It depicts the number of homicides in Philadelphia in 2012, as I just mentioned, which totaled 332. The number of non-fatal injuries in Philadelphia in 2012 was an astonishing 8,000 that were reported now, 8,662. Nationally, there were 88 homicides, which resulted from mass shootings, and 102 non-fatal injuries that resulted from mass shootings. In 2012, at our adult hospital, there were 973 people that came through the emergency department for a violent-related injury. Our children's hospital, St. Christopher's Hospital for Children, there were 681 children that were treated for non-fatal injuries. These are pretty staggering and astounding. Again, the scope of the problem with regard to violent injury, it's a recurrent problem, and studies have demonstrated that at 5 years, re-injury rates for a penetrating injury are as high as 45%. Also, of that same population, of that same study group, at 5 years, the mortality rate is as high as 20%. Violent injury is potentially a traumatic experience. In urban community settings, there have been studies that demonstrate 15 to 23% have a lifetime history of PTSD, post-traumatic stress disorder, among victims of assaultive violence. In urban hospital settings where studies have been done, PTSD, 27% at 3 months after the violent injury, 18% 1 year after, and 41% demonstrate acute stress disorder within 1 month of the violent injury. And I also want to reflect that the psychological sequela, which persists long after physical wounds have been treated, which is really what has given us the impetus to have the intervention in a location where we do. Many don't seek mental health services because of the associated stigma, lack of trust in mental health services, mental health service providers. Many are uninsured and unaware of victims of crime services that are available. This is a very, very non-exhaustive, oversimplified schematic of how we see the cycle of violence. As I see it as an emergency physician, we see many of our young people that come in when they're injured, re-injured as a result of retaliation or just any other issue. They're shot, stabbed, assaulted. They're treated in our emergency department. Often they're discharged. If the injury is severe enough, they're admitted to the hospital. What goes unaddressed, as I mentioned previously, is the psychosocial aspects that go along with that physical injury, which in some instances leads them to self-medicate, get a weapon, and it feeds right back into that cycle of violence. And what often happens is that they, in fact, go on the trail of being killed, or they end up incarcerated. We see this moment for us, if you see the little highlighted area in the hospital, where we have a moment to promote change, to promote alternatives, and offer those services to the young people. What you notice in the center is that of trauma that we feel, and I'm sure many of you also recognize, does in fact go unaddressed in the population that we're describing. And we're subscribing to trauma being one of the core issues that promotes this cycle of violence. With that in mind, I'm going to shift over into how we see this through the lens of trauma. It's one that guides our practice, but it's also something that we take into consideration. I'm not sure, I'm sure many of you are familiar with the Adverse Childhood Experiences study. I'm just going to take a few moments to briefly walk through it, just to make sure that we're all on the same page. What we mean by that, the Adverse Childhood Experiences study was a major public health study that was first published in about 1998. The original Adverse Childhood Experiences study looked at 10 categories, which are listed up on the screen, of people who were 50 years or older, and asked them about experiences before they were 18. And those are the list of things that they asked. What was found, which was really interesting, is they found that 1/3 of the population had a 0 ACE score, Adverse Childhood Experiences score. 1 in 4 had an Adverse Childhood Experience score of 2 or more. 1 in 6 had an Average Childhood Experience score of 4 or more, and 1 in 9 had ACE scores of 5 or more. This study is pretty astonishing because it means that there's a very high rate of exposure to adverse childhood experiences in the general population. What also is pretty informative and also surprising is that there was a strong dose-response relationship between the number of adverse childhood experiences that someone encountered and the development of chronic illness. Things like smoking, chronic obstructive pulmonary disease, heart disease, diabetes, obesity, hepatitis, and so on. So as you can see, this information really has led many researchers and many practitioners down the path of recognizing how adversity, trauma, and stress really do feed into human development. We did a cross-sectional study of members involved in our program, and we found that with regard to post-traumatic stress disorder, 77% of the patients, and these are young people between the ages of 19 and 29, 77% of those patients had full-blown PTSD. With regard to childhood adversity, 50% had adverse childhood experience scores of 4 or more. What that really has said to us is that, again, we've identified and recognized this in our young people at a very vulnerable moment. Again, some instances, some people would say that it's too late, it's after the fact, when in fact, when is the right time for some intervention to take place? We also know and have found that hospital-based programs do in fact work. Dr. Cooper, a trauma surgeon at University of Maryland Shock Trauma, has a violence intervention program, and found that patients who were not involved in an intervention program were significantly more likely to be arrested for a violent crime, convicted of a violent crime, involved in repeat violent criminal activity. Dr. Zun, an emergency physician in Chicago, showed a reduction in self-reported re-injury and also increased utilization of referrals. And over in California, a hospital-based violence intervention program showed a reduce in at-risk youth involvement in criminal justice system. So all that has really fed us in terms of how we do our work and how we see our work. And I'm going to shift a little bit to talk about our program as to how it's came into place. I mentioned that we recognize and we do a good job of taking care of the physical wounds. However, there is the challenge of those psychosocial or psychological wounds that goes unaddressed. And so we feel that there should, in fact, be something in place. Our program started in 2008 at Hahnemann University Hospital. We roughly see about we're able to touch in some form or fashion roughly about 90 clients annually. If we had more capacity, we probably could do more, but based on what we have, we're able to touch and influence about 90 clients. Our children's hospital sees about 70 clients. Again, based on capacity, we see many more come through for violent-related injury, but with our capacity, we're able to have an impact on 70. What our work is based on is really two theories: the theory of that teachable moment as well as trauma theory. The teachable moment, one in which individuals are particularly receptive to interventions which promote positive behavior change. Studies have demonstrated that victims of violence are receptive to that intervention. Also, effectiveness of interventions at these moments in healthcare settings like smoking cessation, alcohol use, and drug use have demonstrated to be effective. With regard to trauma theory, we were saying that trauma theory pervades everything, from staffing to the model itself to screening to the way that we engage our patients and clients, screening and assessment and referral as well. And what trauma theory represents is a fundamental shift of thinking from the supposition that those who have experienced psychological trauma are sick or deficient in moral character to reframe that they are injured and in need of healing. So moving away from that spectrum where they're sick and they need institutionalization, they need treatment, or they're bad and they need punishment or punitive measures, right in that continuum is that fact that they're injured. And so we feel like we work in that, right in the middle there, working with these young people who are injured and helping them heal. This is just a brief schematic of the program itself, the process. I'm not going to go through it in depth, but it just really shows you the different elements. At the bottom in orange, you'll see the different elements of the program, which are based in trauma theory. Again, safety, emotional management, loss, and future are part of the trauma theory, how we work with the young people, how we work with them to feel safe, how we work with them to manage their emotions, deal with loss, and have a future. All this is grounded in assessment, mentoring, psychoeducational groups, navigation, and case management. We work to identify PTSD, adversity, and educate the patients around the feelings that they're experiencing. We connect them to mental health services, and whatever identified needed services. Deconstruct their idea of the code of the streets, recognizing in some instances they might think that having a gun would make them feel safe, but deconstructing that idea. And our psychoeducational groups based in trauma theory really work to give the young people a sense of safety, dealing with emotions, dealing with loss, and having a future. This is a very busy slide, I apologize, but it's one that we have to present when we're talking about the research because, again, we want to move practice to evidence-based research. And so we have a design where we're looking at the young people that come through our emergency department and the control group at Hospital University of Pennsylvania. And what we're saying is involvement, bottom line is we're hypothesizing that involvement with our program decreases the development of post-traumatic stress disorder, depression, improves sleep quality and quantity. And finally, the suggestions that we have for additional research that needs to take place is to study the impact of trauma on boys and men of color and include that over the lifespan, and also intervention research. We encourage support around practice-based evidence to become evidence-based practice. Thank you.
Okay, Dr. Corbin is modeling, staying on track. I love it, and Claire is smiling over there. I want to also welcome, and I forgot to do that in the previous introduction, welcome our web audience, and to remind the group that we're going to have question and answer period at the end of all 3 sessions. The next speaker is Dr. Jim Jacquard, who is a professor at New York University.